Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Picture this. It's the most high-stakes, clock-is-ticking scenario you can imagine in emergency medicine. A patient is wheeled in, unconscious, showing neurological deficits. They're on a cocktail of complex blood thinners. Could be warfarin, maybe apixaban, and the imaging confirms the absolute worst. A catastrophic, life-threatening intracranial hemorrhage. Every second counts, and the clinical decision you're about to make on reversal. Well, it's a tightrope walk between stopping the bleed and causing a massive stroke.
And that's precisely the challenge in modern critical care. It's not as simple as just stopping the drug and, hoping for the best. In these critically ill patients, you've got things like kidney failure, sepsis, liver disease. They're constantly complicating the picture. You need an immediate, nuanced, sort of global sense of their coagulation status. And the traditional measures, they often just fail to reflect the true complex state of their clotting ability.
Okay, so let's unpack all of this. Our mission in this deep dive is to synthesize the current evidence and the guidelines, really the battlefield manual for 21st century emergency coagulation management. We're going to walk you through reversing these incredibly diverse anticoagulants and antiplatelet agents. We'll distinguish between those amazing new specific antidotes and the older non-specific methods that, frankly, still dominate a lot of hospitals because of cost and availability. We're aiming for a really comprehensive, structured understanding here.
Absolutely. And before we even get into specific drugs, the foundational principles for managing any major bleed are universal. You just can't skip them. The first, most immediate step is completely non-negotiable. Discontinue all anticoagulants and antiplatelet agents right away.
And while that's happening, you're already securing the airway, getting large bore IVs in, and starting local hemostatic measures. Pressure, packing, whatever it takes. The guidelines are so clear on this. Initiating reversal must not delay resuscitation and local control. That delay can cost a life.
Exactly. Supportive care is just paramount.
Yeah.
You need volume resuscitation with isotonic crystalloids to keep them hemodynamically stable. But there are 2 points here that are critically important for you to remember. You have to actively correct hypothermia and acidosis. These two conditions, so common in shock and trauma, they actively and severely worsen coagulopathy. If your patient is cold and acidotic, their blood simply will not clot no matter what antidote you give them.
And for those critical enclosed bleeds, like in the brain or a massive bleed in the abdomen, you're getting specialists involved early. Neurosurgeons, general surgery, interventional radiology. Stabilize first, then reverse.
Correct.
Okay, so we've got the patient stabilized, supported. Now the diagnostic dilemma. Before we jump into the specific reversal drugs, how do we even know how coagulopathic a patient truly is? Especially when the traditional tests we've used for decades are, well, known to be unreliable in these complex cases.
This is where we have to talk about advanced diagnostics. Specifically, viscoelastic hemostatic assay, so thromboelastography, TEG, or rotational thromboelastometry, which is ROTEM. Your traditional tests, JASP-PT, INR, APT, they only show a tiny part of the story. They just measure the in vitro clot initiation time. It's a one-dimensional static snapshot.
But TEG gives you the whole movie, right? The full dynamics of the clot.
It does. It gives you a global assessment. It measures both the cellular parts, so the platelets and the plasma parts, the factors of clot formation, strength, and then breakdown. It's the entire process in real time. And the literature backs this up. In complex populations like patients with cirrhosis or trauma or critical illness, TEG clearly outperforms the traditional tests. It gives us that essential clinical guide for what factors we need to replace.
That sounds absolutely perfect for an emergency. So if TEG is so clearly superior at giving that global picture, why isn't it the standard in every single emergency department? Is it an issue of availability, cost, or is there a big learning curve that makes it hard to use in that chaotic environment?
You've really hit on the exact tension there. While TAG is superb at defining the type of coagulopathy, is it a platelet problem, a fibrinogen problem, a factor deficiency? It's expensive. It requires specialized equipment, and the staff needs specific training to interpret these pretty complicated graphs quickly. So while it offers incredible diagnostic resolution, a lot of community hospitals still relied on the faster, cheaper, if less accurate, traditional labs, which means a lot of critical reversal decisions are still being made with incomplete data.
That's a huge piece of real-world context.
Yeah.
Okay, let's move to the agents themselves. Let's start with the one that defined anticoagulation for half a century. Warfarin, the vitamin K antagonist.
Warfarin is still highly relevant, and its reversal strategy is just foundational knowledge. Its long half-life, it can be 20 to 60 hours. That's the main source of the problem. It leads to this prolonged bleeding risk. And you have to remember the specific danger here. VKA-associated intracranial hemorrhage is 7 to 10 times more frequent than in people who aren't anticoagulated.
So they're bleeding badly on warfarin. What's the strategy? I know it's a two-part approach.
Correct. And it's a crucial two-pronged approach. You're targeting both immediate and durable reversal. For the immediate effect, getting clotting factors back now, you must use prothrombin complex concentrates, or PCCs, specifically the 4-factor type 4F-PCC. It's FDA approved and contains factors 2, 7, IX, and X.
And we used to lean so heavily on fresh frozen plasma, FFP. Why are PCCs so much better now? Why are they the preferred agent?
Well, PCCs are superior in almost every clinical way for an emergent reversal. First, volume. They're highly concentrated, so you give a much smaller infusion volume. That's critical if your patient has underlying heart failure or is hemodynamically unstable. Second, speed. You can administer them faster, and they achieve a more consistent and rapid INR reversal, usually within just minutes. FFP has to be thawed. You need huge volumes. That often leads to volume overload, transfusion reactions, and it's just slower. PCC dosing is weight-based and INR adjusted, usually around 25 to 50 IUs per kilogram.
So PCC, for immediate volume-sparing factor replacement. What about that second prong, for durability?
That's the durable reversal. That's using vitamin K, or phytonadione. You give 10 milligrams IV, infuse slowly, and this is non-negotiable. You give it concurrently with the PCCs. The PCC factors are exogenous. They'll get used up. Vitamin K provides the substrate the liver needs to start making its own functional clotting factors again. But here's the trade-off. Vitamin K takes 4 to 6 hours to really start reducing the INR. It's a marathon, not a sprint. You need both.
That need for both the fast-acting PCC and the slow-acting vitamin K really drives home the mechanism of warfarin. It's depleting factors, so you have to replace them, and then you have to fix the production line. Now, here's where it gets really interesting and honestly a lot more complicated. The newer drugs, the direct oral anticoagulants, the DOACs, they need completely different strategies because they don't deplete factors, they just inhibit them.
Precisely. Let's start with a direct factor Aza inhibitor, so drugs like apixaban and rivaroxaban. They directly block factors Aza, which prevents the formation of thrombin.
And for these FXAIs, we have a very specific antidote, andexanet alpha, often known by its trade name, Andexa. What's the mechanism here, and what makes it so effective?
Andexanet alpha is essentially an engineered decoy molecule. It's a modified inactive form of factor ZA. When you infuse it, it acts like a high-affinity sponge. It just binds to and sequesters the circulating FXA inhibitor drug molecules. By pulling the inhibitor out of circulation, you rapidly restore the native factor ZA activity, and that lets the coagulation cascade get going again.
And the main evidence for this is the Annex-A4 trial.
That trial was critical. It showed a rapid and, frankly, dramatic effect on lab measures. A median 92% decrease in anti-FXA activity within minutes of the bolus. And clinically, they got excellent or good hemostatic efficacy in 82% of the evaluable patients with acute major bleeding. I mean, that's rapid, measurable reversal.
But despite that incredible efficacy data, there's still a ton of controversy. Mostly because 4FPCC is still used widely, often off-label, for these bleeds, especially in smaller centers where andexanet alpha just isn't on the shelf. How do we make sense of the conflicting data on which one is better?
It's a huge clinical tension, and it's rooted in economics and limited head-to-head data. Some of the early, smaller retrospective studies, they found no significant difference in efficacy between andexanet alpha and 4FPCC. But as you noted, there was that larger U.S. hospital-based observational study that suggested treatment with andexanet alpha was associated with a 50% lower odds of in-hospital mortality compared to 4FPCC after adjusting for confounding factors.
50% lower mortality. That's a massive signal. You can't just ignore that. But when you say observational study, how careful should we be? Could selection bias be skewing that? I mean, maybe only the sickest patients who needed the most aggressive, expensive treatment got Andexan alpha in the first place?
That is exactly the right critical question to ask. Observational studies are inherently prone to bias. It's plausible that centers that can even administer andexanet alpha also have, superior overall critical care resources, and that might influence mortality independent of the reversal agent. However, the strength of that lab data, the 92% neutralization, that's hard to argue with. But clinically, both agents have a very serious shared downside.
Which is the high risk of clotting.
Yes. For andexanet alpha, the thrombotic event rate in NXA4 was reported somewhere between 10 and 18% within 30 days. You are reversing a life-saving anticoagulant, and the body's natural tendency, especially when it's exacerbated by critical illness, is to clot. You stop the bleed, but you dramatically increase the risk of a stroke or an MI or a PE. It's the ultimate therapeutic dilemma.
And we have to remind everyone that the routine coagulation tests are useless here. If you're looking at an INR or an APTT, they are completely unreliable for monitoring FXIS. You need specific anti-AZA assays, which are almost never available in real time in an emergency, which means clinicians are often just flying blind, guided only by the clinical picture.
Precisely. Now let's move to the other major DOAC class. The direct thrombin inhibitors. That's primarily dabigatran. These block factor TIA thrombin directly.
And for dabigatran, we have a highly specific, almost miracle drug in idarucizumab.
Idarucizumab, or Praxban, is a humanized monoclonal antibody fragment. It binds to dabigatran with an incredibly high affinity and specificity. The binding is so strong that it just completely neutralizes the drug's effect instantly. The landmark reverse AD study showed it rapidly and completely reversed the anticoagulant effect in over 98% of patients. It's really a testament to targeted drug design.
Idarucizumab sounds like the perfect solution. But, practically speaking, if I'm working at a smaller hospital and I don't have it on hand, does the dialyzability of dabigatran actually give it a real-world edge over the other DOACs?
It does, surprisingly. Dabigatran has two unique features among the DOACs. Relatively low protein binding, only about 35%, and it's primarily excreted by the kidneys. So these features make it dialyzable. For a patient with profound renal failure, or if idarucizumab just isn't available, hemodialysis is a potential, albeit cumbersome, alternative. For the other DOACs, dialysis is just not effective.
Okay, let's transition to the parenteral anticoagulants, the heparins. Unfractionated heparin and low molecular weight heparin. Even with shorter half-lives, they require really rapid action when a major bleed is happening.
For unfractionated heparin, we have the classic specific antidote, protamine sulfate. It's a small, positively charged molecule that binds to the large, negatively charged heparin molecule. They form a stable, inactive complex. Dosing is pretty straightforward. 1 milligram of protamine per 100 units of heparin given over the last 2 to 3 hours.
But the administration is tricky, isn't it? I've always heard that pushing it fast can cause a disaster.
Oh, it's vital. Protamine must be administered slowly intravenously, usually over about 15 minutes. Rapid administration can trigger really significant adverse events. Severe hypotension, bradycardia, and potentially fatal anaphylactoid reactions, especially in patients who've had protamine before, or NPH insulin.
Now, what about LMWH like enoxaparin? Protamine is used, but the reversal here is notoriously problematic. This is a critical point that you have to understand.
This is where partial reversal becomes a huge clinical issue. Protamine is the most common agent for LMWH, but its reversal is, it's variable and incomplete. LMWH works through both anti-CIA and anti-ZAA activity. Protamine is great at neutralizing the anti-CIA activity, but it's much less successful against the anti-CIA activity.
So what's the actual quantifiable deficiency there? What are we talking about?
We're talking about achieving only, say, 35 to 40% reversal of the anti-SAV effect in some studies. And if you're dealing with a massive ICH, a 60% residual anti-SAV effect it's unacceptable. This is why LMWH reversal remains such a high-risk situation. And to be clear, neither FFP nor PCCs are recommended for UFH or LMWH reversal.
Okay, let's shift gears completely to the challenge of antiplatelet agents, aspirin, clopidogrel, all the P2Y12 inhibitors, and fibrinolytics. This is so common, and it's especially challenging because APAs affect platelet function, which is hard to replace.
Historically, when a patient on, say, aspirin came in with an ICH, the knee-jerk instinct was always give platelets.
But that whole paradigm has been completely shattered by one of the most important trials in this entire field, the PTCH trial. Tell us why routine platelet transfusion is now strongly discouraged.
The PETCH trial was a huge shakeup. It randomized patients with spontaneous ICH, who were on antiplatelet agents, to either standard care, plus routine platelet transfusion. The results were just clear and shocking. Routine platelet transfusion gave no benefit, and crucially, patients who got platelets had worse neurological outcomes and a trend towards more bleeding.
That's a massive finding. So platelets weren't just ineffective, they were actually potentially harmful.
Exactly. The mechanism is still debated, but one theory is that the transfused platelets, even though they're functional, they get activated and maybe contribute to clot instability or even secondary microvascular obstruction. The conclusion is firm. Routine platelet transfusion is now strongly inadvisable if the patient's platelet count is adequate.
So if we can transfuse platelets, what about other agents that improve function, like desmopressin or DDAVP?
Desmopressin is often considered. You give about 0.3 to 0.4 micrograms per kilogram IV. It triggers the release of von Willebrand factor, which improves platelet aggregation in vitro. However, its effectiveness in actually reducing hematoma expansion in an acute ICH is, well, it's uncertain. There's significant conflicting data. It's used a lot, but its clinical impact is really hard to guarantee.
And finally, what about fibrinolytics, like alteplase, the clot busters given for stroke? Is there a specific antidote for a bleed caused by one of those?
I know. There is no specific reversal agent for thrombolytics. Management is focused entirely on replacing the depleted structural components of the clot. So the key strategy is replenishing fibrinogen levels using cryoprecipitate, especially if that fibrinogen level drops below 150 milligrams per deciliter. Cryo is preferred over FFP because it has a much higher concentration of fibrinogen per volume.
And that brings us to the final and maybe most critical decision point, the long game. Once the acute bleeding is controlled, when and if do you restart the anticoagulant?
If we connect this back to the bigger picture, this one decision really defines the patient's future risk profile. It is a complex, highly individualized choice. You're balancing two completely unacceptable risks. The high thrombotic risk, for example, in a patient with a mechanical heart valve or severe AFib, against the risk of rebleeding, especially after an ICH.
So is the general advice to resume therapy, given the high underlying thrombotic risk most of these patients have?
Yes, generally, the net clinical benefit favors resuming therapy. It often significantly lowers long-term mortality. But the timing is absolutely everything. For most spontaneous intracranial hemorrhages without an unacceptably high thrombotic risk, the standard advice is to delay resumption for at least 4 weeks. Observational data suggests restarting around 1 month might be the sweet spot for minimizing the combined risk of thrombosis and death.
But what if they're at unacceptably high thrombotic risk? They have a history of recurrent PEs or a high-risk mechanical valve or an LVAD. They can't possibly wait a month, can they?
Absolutely not. Those patients might need anticoagulation restarted much, much earlier, potentially within 1 to 3 days. In these extreme cases, clinicians often opt for IV unfractionated heparin initially because of its very short half-life and immediate reversibility. It allows for close monitoring, and you can stop it instantly if rebleeding occurs.
And for the much more common GI bleed scenario?
Resuming anticoagulation is still associated with a lower risk of thromboembolism and death than stopping it for good. However, for warfarin-associated GI bleeds, there is some evidence that suggests delaying the restart for more than 7 days might offer a small survival benefit. It just gives the GI mucosa more time to fully heal.
This has been an incredibly deep dive. We've covered the modern spectrum of coagulation reversal. Specific, expensive, effective antidotes like edarakizumab and andexanet alpha. The tried and true, volume-sparing combo of PCC and vitamin K, and these crucial paradigm-shifting warnings from negative trials, the finding that routine platelet transfusions for ICH on APAs are actually harmful.
And this raises a really important question that you need to think about, especially given the costs. Given that we now have specific antidotes that rapidly correct lab values, like how idarucizumab normalizes coagulation tests within minutes, why is the correlation between that rapid lab correction and improved patient outcomes often unclear, particularly when it comes to mortality and long-term functional status?
That disconnect, the lab looking perfect but the patient outcome lagging, it really highlights the complexity of a system that's often permanently damaged by that initial hemorrhage. You have to consider the real-world implications of cost, local availability, and conflicting trial data when you're making these choices, which is why 4FPCC, despite these amazing specific antidotes, is still the frontline choice in so many places globally. Knowing these nuances is truly life-saving knowledge, both for avoiding a bleed and for stopping one.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.